All right, I'll get us started. Vivian, the next slide, please. Good morning, good afternoon, everyone. My name is Terry Camacho Gonzalez, and I'm the director for the Traumatic Brain Injury Technical Assistance and Resource Center, the TBI TARC. Thank you for joining us to learn more about the Behavioral Health Guide considerations for best practices for children, youth, and adults with TBI. This webinar is sponsored by the TBI TARC, which is funded by the Administration for Community Living. The TBI TARC provides technical assistance and support to the Traumatic Brain Injury State Partnership Grant Program grantees and to other TBI stakeholders, including other states, policymakers, providers, people with lived experience with TBI and their family members. TBI TARC is administered by Human Services Research Institute, who I work for, and with the assistance of the National Association of State Head Injury Administrators. The TARC webinars are free and open to the public. Next. We are here today to talk about the Behavioral Health Guide. It can be downloaded from the Administration for Community Living website. The link to the document is on this page, and it's also going to be, it has been entered into the chat. Next. So before we get going, some webinar logistics. So all participants are on listen only mode during the entire webinar. Please use the chat feature to pose questions and to communicate with the hosts. Towards the end of each section, our speakers are going to have the opportunity to respond to questions that have been entered into the chat. So we'll be monitoring those questions. The webinar will be live captioned in English and Spanish. You can access the live English captions by using the external link that's on the screen and will also be entered into the chat. We're also going to have Spanish captions, and you also have to use an external link to get to the Spanish captions. Este seminario de web estará subtitulado en vivo en inglés y español. Para tener acceso a los subtítulos en español, utilice este enlace externo. This live webinar includes polls and evaluation questions, so please be ready to interact during the polling questions. Next. After the webinar, you can send follow-up questions and feedback to the email address tbitarc@hsri.org. Please note that this email address will not be monitored during the webinar. A recording, including a PDF version of the slides, will be available on the ACL website at acl.gov. Next page. And before I get started, we have a poll. But first, I was supposed to introduce myself, and I totally forgot. I am a Hispanic woman with short, dark hair. I have a green background in the back, and I have a beige shirt and a black sweater, red lipstick, and some headphones. All right, now we're going to have our first poll, and it should have popped up on your screen, and we want to know who's here and what roles do you self-identify, and you can select all that apply if you identify as having more than one. We just want to get a sense of who's here. This is helpful for the speakers and also for us as we prepare and put on more webinars to see who are the people joining us. We're going to give it a few minutes. And right now, it could change, but 44%, or so close to half, are direct care staff, social worker, counselors, or care manager, and that makes sense. 34% about service provider, organization employee, and then we have some self-advocates, we have some peer specialists. Someone said they're a social worker on chat. Thank you. A little bit of 5% are research analysts. We are close to almost everyone responded, so I'm going to give it a few more minutes, and then Shaska will close it up and we'll share the results. People are entering in chat. Thank you, Candice. Thank you for joining us. We have some raised hands. You should enter any questions you have in the chat. All right, I think we can close up this. Should we close it up and share the? Can you people see the results? So kind of close to what I said before. All right. Next slide. So now I'd like to introduce my colleague, Judy Detmer, who's going to introduce the panelists and also introduce us to the Behavioral Health Guide. Judy, thank you.
Great, thank you, Terry. Welcome, everybody. It's really exciting to have you all attending this webinar. We're really pleased to be able to present this work, and very hopeful that it'll be of great help to the field. I've been working in brain injury for about 30 years, and I know this is a much needed tool. So I'm very excited to be presenting about this today. So my name is Judy Detmer. I'm Director for Strategic Partnerships at the National Association of State Head Injury Administrators. I'm also a TBI or a Technical Assistant Lead for the TBI Technical Assistance and Resource Center that Terry had mentioned earlier. I'm going to talk about section 1, but before doing that, I wanted to mention a couple of things. Oh, I guess I will also describe myself. I'm a white woman with glasses and short hair. My background are some old looking posters from Hawaii and Minnesota, two places that have my heart. So it's a pleasure to be here today. So one thing I wanted to mention just in the form of transparency is that the National Association of State Head Injury Administrators has several projects and products and resources related to screening and behavioral health that we've been partnering with many of the people actually who will be presenting today, but also outside of those folks. And those resources are available on our website. Many of them are available for free. There are some, however, that there is a fee for. And if you have any questions related to any of our resources, please feel free to reach out. I will put my name and email in the chat, just so in case you need more information, you know how to find me. Next, I wanted to go ahead and introduce all of our presenters. Again, for the sake of time, we have a lot of information to cover in a relatively short period of time. So I'm going to introduce them in the order of which they'll be presenting. That way you have some familiarity with who will be presenting. After me, it will be Thomasine Heitkamp, and Thomasine is a licensed clinical social worker, Chester Fritz Distinguished Professor Emeritus at the University of North Dakota. I should also mention that their full bios are in the PDF version that you have. After Thomasine will be my colleague, Maria Crowley. She's NASHA's Director of Professional Development and Technical Assistance Lead for the TBI TARC, along with me. Following Maria will be Dr. John Corrigan. John is the Director of the Ohio Valley Center for Brain Injury Prevention and Rehabilitation and the Ohio Brain Injury Program. Following John will be Dr. Maria Kayankova. And Maria is clinical instructor in the Department of Rehabilitation Medicine at the ICANN School of Medicine at Mount Sinai. Presenting with Maria will be Dr. Theo Saucides. Theo is a neuropsychologist. He's a speaker and author and an assistant professor in the Department of Rehabilitation Medicine at the ICANN School of Medicine at Mount Sinai. And then wrapping up our sessions today, co-presenting will be Dr. Lindsay Gurin, and she is a clinical assistant professor of neurology, psychiatry, and rehabilitation medicine at NYU Langone, I hope I'm saying that right, Lindsay, Health. And then her co-presenter will be Dr. Michael Cho, and he is a fellow in brain injury medicine at NYU Grossman School of Medicine. So I'm very pleased to have all of these folks presenting with us today. Next slide, please. So I'm just going to quickly introduce the purpose of this guide and kind of the impetus behind developing it. From our perspective with the Technical Assistance Center, we see that many states are struggling with how to support people with brain injury and co-occurring behavioral health conditions. We get asked for a lot of technical assistance around that area. And so we felt like there was a need to develop a guidance for states as to how to effectively support these individuals. The guide is primarily geared towards state government lead brain injury programs. However, really anybody can benefit from reviewing this guide. But we feel that the state government programs are in a unique position to affect policy and increase training and implement practice changes within the state behavioral health system in partnership with their state behavioral health systems. So this guide, which Terry had already mentioned where you can find that, provides states with a tool for initiating or improving partnerships within state mental health systems, and also providing you strategies and tips for how to support people with co-occurring behavioral health and brain injury. Next slide. The guide provides an overview of the prevalence and systematic issues that add to the complexity for support, which I'm sure many in the audience are quite aware of. We review partners and strategies for partnering. We provide insight into training approaches that states might implement, provide an overview of a screening protocol that can be implemented in behavioral health settings. We provide strategies for modifying clinical interventions and guidance for modifying pharmacological interventions. Next slide. So again, I think a lot of you are likely aware since you're attending this webinar, but the co-occurrence of brain injury and behavioral health is really a significant issue in our country. And it is something that I feel we are gaining a lot more traction related to understanding the importance of this. But if you look at some of the data, roughly a third of individuals with brain injury will experience mental health concerns 6 months to a year post-injury. And people with brain injury of any severity have 2 to 4 times the risk of attempting or having death by suicide. Between 23 and 51% of the adolescents and adults sustaining TBI were intoxicated when the injury occurred, and a quarter of people hospitalized for TBIs have a history of substance use disorders. I just pulled out a few data points. There are many more, and we really do know that this issue is a significant issue. Next slide. Some of the systemic issues that states are facing in terms of really implementing effective supports for people with brain injury within a behavioral health setting is multifaceted, but it starts with identifying the brain injury. Oftentimes, those of you working in behavioral health settings are not even aware that you're working with somebody with a brain injury because they may not have been diagnosed, or they may not share that information with you, or they've been misdiagnosed. So one of the first steps in terms of kind of changing the trajectory of success for this population is to start identifying brain injury within the behavioral health system. And that's done through screening that you'll hear about later. Another systemic issue is that brain injury, and rightfully so to a great extent, is considered a medical condition, but has been locked for many, many years now in the medical paradigm. And so what we work hard to do is shift that thinking. There's a medical event that occurs with brain injury, but as people survive and live with brain injury, it becomes more of a behavioral health community paradigm that we need to adopt in order to have people have successful long-term outcomes. That's not to say that we know that that brain injury is a chronic health condition, and so their health conditions may ebb and flow throughout their lifetime, but we're really working to help people understand that brain injury goes beyond medical and becomes a behavioral health and community issue. And that's why this guide is really important. Another systemic issue is a lack of training for the behavioral health workforce, and frankly, a lack of feeling confident that they can support people with brain injury. One of the things that we try to promote is that you're really supporting and treating the behavioral health condition in the context of brain injury. You're not treating the brain injury. And so it's important as we think about training behavioral health workforce, you do have the tools to be able to provide the support that they need for treatment. It's really lacking maybe in understanding how brain injury might be affecting their ability to be successful. And so those are some of the key things that we're trying to tie in. Next slide. In terms of addressing systemic issues, there's a couple of tangible steps that states can take. One is to think about what are the system's policies. And by system here, I'm talking about the behavioral health system, and really to ensure that language is not exclusive of supporting individuals with brain injury. And this can happen inadvertently. Sometimes states get kind of trapped in this chicken and egg question about, did the brain injury cause the behavioral health condition? And what we hope to strive for is that really that is hard to answer, number one. But number two, it doesn't matter per se, because again, we're not treating brain injury, we're treating the behavioral health condition. And so whether, which came first, you're still treating someone who has a diagnosable behavioral health condition. The second is to develop and implement training protocols so that people feel confident and they have the skill set necessary to intervene on behalf of people with brain injuries. And it's really demystifying brain injury for the behavioral health system. So there are two tangible steps that you can take away. Next slide. I'm going to entertain any questions that you have right now, and then I'm going to turn it over to Thomasine to talk about partnerships. So are there any questions at this point?
Please enter your questions into the chat. I see some people raising their hands.
Okay, I'm not seeing any, so I think I'm going to keep us moving, and we can come back and I can answer in the chat as well. Oh, okay, I see. Why do you think there is such a disconnect with behavioral health and brain injury? Well, I honestly think it's partly because of the paradigm that I mentioned earlier, that brain injury has been considered a physical condition. And there's this kind of separation in people's mind between behavioral health and physical conditions and medical conditions. So I think that has led to some of the separation. The other issue is around funding, to be really frank. Those are some of the policy issues that we have to address in states, is that people get concerned that if they support people with brain injury, it's going to require much more funding. They don't have funding from their states to do that. And again, that's why we promote the thinking that it's not that you're developing a whole different system of behavioral health support for people with brain injuries. You're integrating people with brain injuries in the existing system, but giving the professionals in that system the knowledge and ability to understand how brain injury affects their ability to be successful in treatment. Okay, I think that might be it. And I see John added some things too, so thank you for doing that. All right, I'm going to turn it over to you, Thomasine. Thank you.
Thanks, everyone. I'm thrilled to be here with you from Grand Forks, North Dakota. I am white. I have long red hair. I come to you from my office that is decorated with fun North Dakota art, including grain silos, daisies, and some decorative cows. So I try and bring a little bit of who I am as a North Dakotan and someone who values the complexities of partnerships in rural communities. So I'm going to be talking a little bit about partnerships today. And what I will say as we kick this off is this material that I'm sharing with you is based on my errors, my mistakes in the past that I learned from. When we were working with post-pandemic, we were doing all kinds of collaboration on telehealth. And I could see that some of the partnerships were not as effective as I'd hoped. So I wrote a quick guide on cross-system collaboration, just as a job aid. Well, that job aid just took off with many people using it and it getting branded. It was part of work I was doing in a grant for SAMHSA, Substance Abuse and Mental Health Services Administration. And it occurred to me when Judy and Maria called, Judy Detmer and Maria Crawley, about writing something about partnerships, that I'd taken a little bit of a dive, and I'd also taken a dive in collaborating with them on a product that we call traumatic brain injury and substance use disorders, making the connection where I assisted with editing that project. And if you want to learn about a topic, one of the best ways to do that is to edit. So this was an opportunity for me, and I appreciate the opportunity to participate. Next slide. So advantages to partnerships. We always say, you need to partner, you need to collaborate, you need to work together. Well, that isn't that easy, but the research is very clear that effective partnerships will enhance your capacity to serve clients. And those of you that are on the call or you're persons with a traumatic brain injury, you know when you're involved in the service delivery if the partnerships aren't working. You know when you're doing case management where those partnerships fall apart. So I just want to really do a shout out for the audience that's with us today in terms of your capacity to understand partnerships and to learn. So those best practices, we should be able to do warm handoffs in referral. And since my background is on working with a lot of SAMHSA grants, we talk about SBIR, screening, brief intervention, and referral to treatment. And that screening should be holistic and should be a process that's supportive for that patient or client. So increasing our knowledge base through learning more, we all have capacity to learn, and improving our organizational capacity. Those of you here today, most of us represent grant-funded organizations, universities, healthcare centers. So we work in large organizations, and oftentimes we're just a small piece in that organization. And so we need to work within that larger context. So engaging new audiences, what Judy Detmer did when she started to work with our Region 8 SAMHSA-funded effort in very rural states to expand knowledge in traumatic brain injury and substance use, that led to the toolkit that I mentioned earlier. So building those organizational networks is critical, and it was through that relationship of doing this training that I was brought forward to do some writing on the toolkit. Next slide. So ingredients to effective partnerships. We have to have a shared vision. We have to understand our vision. We have to have a purpose. What's our purpose? And those you can read in websites, and you can see how your vision and purpose might align with another organization in terms of serving persons with traumatic brain injury. But the mutual trust and respect is oftentimes where those partnerships fall apart. In the end, this is all about relationships and relationship building and the trust in those relationships. It also requires what we call transparent communications. And those fears sometimes that people are frustrated and send an email and you don't know who's blind copied on that email, and you don't know exactly where anger is coming from that partnership. So really making those communications transparent. So for the case managers in the group, for example, those social workers looking at what's working and what isn't working and being transparent in those communications. I serve as part of a mental health board where we were involved in a case situation where we need to look at some of our policies. You bring that information forward, that's helpful. The other piece is flexibility. You're not going to start partnerships and they're going to remain the same. There's turnover in organizations. Organizations are fluid and they're flexible, and they often will change based on administrative leadership. So that capacity to be flexible is really very critical. Next slide. Anticipate challenges. Partnerships come with challenges. There's no way around this. People bring themselves and their personality, their understanding. So as we look at expanding that effort to broadly look at behavioral health and substance use and some of the data that Judy provided, that was not data that I used in training on substance use and mental health in the past. But once I partnered with Judy, I understood that data differently. And so that challenge of not having a good enough understanding, which was encouraged, through this partnership with the National Association of State Head Injury Administrators. So that collaborative process involves, and this is where we get hung up as well, what kind of technology do you use? And people come to me and say, what kind of program management software or case management software might work? And I often respond by saying something people will use. And sometimes it's just that simple, that the technology needs to be nimble and available, and there needs to be a commitment to use it. The other piece is the importance, as we look at partnerships, and a commitment to culturally responsive practice, that diversity, equity, and inclusion. We only have to look at the data to see populations that don't receive the same level of care and supportive care, and making those kinds of changes. And for someone who grew up in a town where my family was a tenth the population, sometimes that's access to care in rural communities. In the communities where I live, people will drive maybe up to 2 hours one way to see a psychologist for a diagnosis or to see a neurologist, and that might be even further. So, having that sense of availability, having an understanding of culture and a commitment. So next slide. So lessons I've learned, when we look at this work, we need to make a commitment to due diligence. And that means acting professionally. We need to make a commitment to avoiding grandstanding with partners. One of the lessons I often used in my classroom was praise publicly and express concerns privately. Right? Don't elevate yourself above the group. And organizations have different capacity. I work at a fairly large institution for the Midwest, and so I have capacity that smaller institutions might not have when we partner with them. This is a critical piece. Do your share of the work. Be honest and communicate. I talked about transparent communication. Have a commitment to doing your work. And that kind of blaming of, there's all kinds of reasons why things don't occur. That hurts partnerships if you're not being honest about that. Praise accomplishments publicly, maintain a focus on the objectives and the needs of the population you're serving. So what are those needs? What's your focus and what's your direction? What do you hope will move forward? And the next slide, very simply, is just partners for your consideration. This is all in your materials on the guide that people have provided. I put a short summary of each one of these partners for your consideration. So thanks so much for your time today, and thanks for the opportunity to be part of this toolkit. I don't know if there's time for questions. I think I went over a little bit.
I'm scanning right now, Thomasine. I'm not seeing questions. So I think we're okay, but when you're done, if you can monitor the chat too and see if anything pops up, that'd be great.
Thanks.
Maria, I think you're up next. Maria,
hi there. Can you hear me? There I am. Hi, everybody. I'm Maria Crowley. Next slide. With NASHA and the TBI Technical Assistance and Resource Center. Very happy to be a part of the creation of this guide. And as you use it, we hope that you'll find it beneficial. And if you have questions, you can certainly reach out to us. Next slide. And I am a white woman with Cuban roots, and have a bookcase sitting behind me. I'm wearing a white shirt and a multicolored jacket. So instead of talking with you about how to provide training, I wanted to really focus, as we worked on this guide, we focused on why training is so important. And many of you already provide training and are used to providing training, but why is it so important with the behavioral health system? First of all, and probably foremost, and I should have put it at the top of this slide, as Thomasine has pointed out, it's part of establishing a strong partnership and some trust and mutual respect and awareness on both sides of the fence. A lot of why you provide training really gets back to that. You can't assume that everyone in the behavioral health system is knowledgeable or has expertise about brain injury just because of where they sit, or that they're aware of some of the prevalence statistics and co-occurring issues and statistics that Judy shared with you earlier. I am pretty sure I speak across all states when I say for behavioral health, with very few exceptions of those who are fortunate enough to have fabulous private health insurance, the burden of responsibility for providing behavioral health services and supports falls to the state behavioral health system. So it's a system that has a lot of people to serve, a wide variety of people to serve, often with very limited resources. And it's important to know that as you approach them and start talking about training. Something else that's very important to be aware of overall is that providers in a behavioral health system, much like all systems, if they have not spent a lot of time getting training and kind of immersed in brain injury, often providers tend to think that if they have met one person with a brain injury, that person represents all people with brain injury. And many of you know that that's not the case. People with brain injury are like snowflakes. There is no one representation for all. They all have very unique needs, very unique challenges. And if someone's met a person who has mild behavioral health issues, they may tend to think that everybody falls in that basket, or that the reverse is true. And that's just not true. So training is important because it increases awareness of brain injury. And that needs to happen across all areas of behavioral health. Why? Because then behavioral health systems can reduce risk for decompensation of issues, risk for relapse if someone's in recovery, risk of crises, and certainly important is the risk of suicide, ideation, and prevention overall. So if you reduce those things, then you can increase successful intervention in a system, and everybody wants that to happen because it's best for the people that they're serving. Does everybody have to be an expert in brain injury within behavioral health? No, they don't, but they need to know that it's there. As Judy mentioned to you, something that's key within behavioral health, as with other systems, a staff person or provider in mental health may be working with someone who has a traumatic brain injury and they're not aware of it because it's not been diagnosed or it's been misdiagnosed as something else. They may be working with a person who themselves doesn't know that they have experienced a brain injury. Or they may be working with someone who knows they have a brain injury, but they may not know the extent to which some of the challenges that they're having are associated with that brain injury. So it's really important for everybody to have some level of training. Different levels of providers are going to need different kinds of training, but everybody needs to know the basics. And then some need to know beyond that. And why is that so important? Because again, it leads to better outcomes and a better partnership with your state mental health program. Next slide. There are a variety of trainings. We tend to approach this in terms of thinking in tiers of training, from the basics that everybody is going to need, that is included in the guide, causes, symptoms, challenges associated with brain injury, resources that are available, some basic information about fundamentals. So from there is an intermediate level of training that is going to involve a little bit more information and exposure. So that might include different kinds of screening tools that Dr. Corrigan is going to talk about, why screening is important. It might begin to take a look at some therapeutic approaches. And as Judy said, you can still serve people with a lot of the tools that you have. Sometimes it just may be a little bit of tweaking, for some successful intervention. And then advanced training might be reserved for those who are prescribing medication, providing significant therapeutic intervention, those who are encountering people for whom harm reduction, suicide prevention are key. And they may need much more training, and it needs to be provided by a peer who's very knowledgeable in the field of brain injury and behavioral health. Of course, the enemy to training and successful training tools is what? Staff turnover. It occurs in every field, and it certainly occurs in behavioral health. It's important as you think about providing training to your state behavioral health system that you incorporate some solutions for meeting that challenge of staff turnover into your training plan. So as I mentioned, there are a variety of platforms you can introduce training that you guys probably are aware of already. You can do it virtually, you can do it in person, you can have it recorded and embedded in a website that people can access for a lot of the training components that you're going to want to provide. Next slide. There are a number of resources in the guide that we have shared with you. Use what's out there already, maybe instead of taking time to recreate the wheel. You can certainly call on us, your TBI TARC staff, and there's a lot of information on the website. There's a lot of information through NASHA and also information on the website. Your state brain injury program is well versed in providing training on brain injury and behavioral health. The state affiliates and advocacy organizations through the U.S. Brain Injury Alliance and the Brain Injury Association of America, and the protection and advocacy programs in every state. Last but not least, the Traumatic Brain Injury Model Systems Knowledge Translation Center has a host of fact sheets and resources that are available for you in visiting those websites. They are listed in the guide. And then beyond any of these, there are some resources that you can reach out to us for customized training, customized tools. We'd be happy to help with any of those pieces. And I think that's it. Next slide. Any questions related to training? Don't see any yet. So I'll turn it over to John Corrigan. Thank you.
Thank you, Maria. And next slide. I'm John Corrigan. I am a white male with short gray hair that I like to pretend is blonde. I'm wearing glasses, a white checkered shirt, and a blue blazer, and I have bookshelves over my left shoulder and an abstract painting over my right. Next slide. I think it's important to start with the key question, and why would you screen for traumatic brain injury? And as you see listed here, that it is not uncommon, doesn't happen to everyone, but it's not uncommon for the effects of a brain injury then to cause weaknesses that may interact with the success of the treatment you're providing. And it really, these 4 bullets are things that could affect any treatment that you're providing. And so it is important to know about a history of brain injury so that you know to look for and accommodate some of these problems. These are not these are all overcomable if you know they're there and can make simple accommodations. Advance. However, the screening for TBI is not as simple as just asking somebody if they've ever had a brain injury. You would never do a diagnosis of schizophrenia by saying, have you ever had schizophrenia? What we describe in the guide, and I'll just cover very briefly here, is some systematic, proven ways of getting at a person's lifetime history of traumatic brain injury, so that you know the odds that there may be current day effects of that past history. Understand that anywhere from a quarter to a third of the general population, everybody, has had at least one traumatic brain injury in their life. So it's not just whether you've had it, it's the severity, the cumulative effects, how old you were, and how recent. Next slide. It's also important to know in screening that the techniques we use, which is a retrospective self-report that I'll talk more about, are quite different from the techniques we use to diagnose or identify a traumatic brain injury that occurred recently. There we use neuropsychological assessment or imaging and biomarkers, but those are good for recent injuries, but they do not get at a person's whole lifetime. And you say, well, maybe we could look at medical records and then we would know. Recent study done by CDC found that about 60% of traumatic brain injuries experienced by adults do not receive medical care, so they'd be nowhere in the records. 40% of traumatic brain injuries in children. So we need to have this way of querying the individual so that we can figure out just if they've had a significant history of traumatic brain injury. Advance. So we use this retrospective self-report, so-called gold standard. We know it has some weaknesses, some that I've listed here and are described more, talked about more in the guide. But there are better ways to ask. That's the bottom line. And that's what the standardized tools that we're going to look at in a moment, they do. That's what they do. They ask in a proven way to minimize some of these weaknesses by not asking a person to self-diagnose, by helping them to recall particularly less severe injuries that they may not otherwise come to mind, or not relying on just symptoms, but using signs of the traumatic brain injury. Next. These are some of the screening tools that have been developed. All of these have a level of validation work behind them, so they're not just something somebody made up. There is a full table in the guide that is kind of shown there, very small on the right, that looks at some of the characteristics of these. I'll just mention here that with Jennifer Bogner here at Ohio State, we developed the Ohio State University TBI identification method that we're going to talk about a little bit more in a moment. Next slide. So I won't bore you with a long talk about reliability and validity, but it really is important when you're using a screening that you know that this has been looked at in the screener you're using. Reliability is just if I ask again, would I get the same result? And advance. And validity is this result I'm getting, is it really what I'm looking for? And there in screening, there's a little more of a subtlety in that the kinds of validity vary. Somebody may screen because they want to know for sure exactly what traumatic brain injuries a person's had in their life. But somebody else may be screening because I want to know how likely is it that given their past, that today, as I work with them, they will have consequences. They're going to be showing some of the effects of that injury. And that's particularly in the behavioral health setting, the critical question for validation. Next. So this is just a recap of what one of those methods are, the OSU TBI ID. It's relatively short. It just takes 3 to 5 minutes. Training is also very quick. It's been subjected to multiple studies looking at reliability. It has a lot of evidence for really all kinds of validity, whether corresponding with medical records from the time of the injury or injuries, or being able to predict current functioning. And in a number of studies now, it's been shown to correlate with things like structure, brain structure and function. So it gives multiple dimensions: one's worst lifetime injury, age, that you first had an injury, whether you've had multiple, when the most recent were. And those are the kinds of data points we need to be able to say, there's a red flag here. As I'm working with this person, I should be looking out for cognitive or behavioral issues that are a result of the brain injury. And I'll say here, it can't be emphasized enough, that many times in my work, I've seen where effects of the brain injury are misperceived by the therapist as reflecting a person's motivation for treatment or their commitment to the treatment. And when that mistake is made, it can severely undermine the therapeutic alliance. And so it's really important that if there is that history, that we be on a lookout for it. And next slide. Just real quick, and we don't spend enough time on this in the guide, but that there are other acquired brain injuries. TBI is just one kind. Of particular interest in behavioral health are anoxic and hypoxic injuries, meaning that where the brain was denied some oxygen. It can leave some of the same residual effects as a traumatic brain injury. Both of them disproportionately affect the frontal lobes of the brain, and thus what we call executive functions. If you're going to screen for it, you need to remind folks of ways that it might have occurred and get some idea of the severity of that oxygen loss, whether it was just to lose consciousness, or maybe it actually required somebody to be revived via CPR. Many forms of anoxic and hypoxic injury do not receive medical attention, so it doesn't work as it does with some other acquired brain injuries like stroke or others, to ask somebody, have you ever been treated for, or have you ever been diagnosed with? That's a technique we can use for screening in other acquired brain injuries, but for anoxia and hypoxia, it doesn't work as well. So just a little aside on acquired brain injuries and advance. So I think I didn't do too bad on time. If there is a question.
Not seeing any questions yet. And thank you to those of you who are putting them in the chat. And if we don't catch them during the individual presenters, we'll get to them as they're watching the chat. But John, one came in: would the screening tools be appropriate for clients with severe mental illness such as schizophrenia?
It would depend on their current, kind of consciousness, awareness. So somebody who, is confused and, and not aware of their current surroundings may not be a good enough reporter. So one might have to use a significant other or proxy instead. But somebody who has been stabilized from schizophrenia or other psychotic spectrum disorders can be good reporters and have been, and it's been used with that population.
Yeah, that's great. She followed up by saying most of her clients are poor historians when self-reporting. So sounds like if they have a proxy, that could be a way to get around that concern.
Mm-hmm.
Okay. All right. I think that's it, John. Maria and Theo?
Yep, I'm ready. All right, so I'm Maria Kayankova. I'm a white woman with brown hair pulled back. I'm wearing a black sweater, and my background includes a few art pieces on white walls. So in this section, Dr. Saltsides and I will provide a brief overview on how to modify interventions for individuals with TBI. And I'll start by talking about diagnosing mental health disorders in this population. So when diagnosing Please, next slide. Thank you. So when diagnosing psychiatric disorders in individuals with TBI, it's important to know the prevalence. So individuals with TBI present with a range of psychiatric disorders and at a higher rate than the general population. Some of the most common psychiatric conditions that individuals with TBI are diagnosed with or may present with include mood disorders, anxiety, and PTSD. To minimize misdiagnosis, I think it's important for providers to consider whether emotional and behavioral symptoms are neurological in nature or psychological in origin. So some providers might not consider that the cause of some emotional or behavioral symptoms might be neurological or due to the brain injury itself. And some traditional psychological treatments or psychiatric treatments might not be as effective in such cases. And while the cause may not always be clear-cut, and often it's not, it's important that I think we consider both. I think it's also important to consider modifying the use of screening measures and assessment measures for individuals with TBI when possible. Although diagnostic methods and procedures don't generally differ for patients with TBI, it is important to consider limitations of existing measures or methods for use with this population. We often collect collateral information, sometimes have to read measure items or instructions to patients depending on their different challenges. So there are ways to modify these instruments. It's also important to consider the impact of reduced awareness and cognitive functioning on the assessment process. So that's why using collateral information, using family members to fill in some of the gaps can be really important. Ideally, providers would also select measures that are appropriate for individuals with TBI. There are a few great resources out there available to help providers sort of reference the different types of measures that have been either developed for, validated, or modified for individuals with TBI, including the Shirley Ryan Ability Lab Rehabilitation Measure Database or the NINDS Common Data Elements website. These are in the guide, so you can reference them there. The other thing is that screening for and/or identifying issues related to TBI can help providers make appropriate referrals to TBI specialists. So picking up some of these issues related to TBI, including cognitive impairment, can help make referrals to TBI specialists. I'm going to pass things over to Dr. Salcides, who's going to discuss treatment. Next slide.
Thank you, Maria. Hello, everybody. I'm Dr. Theo Salcides. I'm a white male with dark brown hair, a light beard. I'm wearing a light blue shirt, and I'm standing in front of white walls with some framed landscape pictures on them. You heard a lot today. So we talked about identification and we talked about screening. We hope we gave you a good sense that because of the prevalence of TBI itself and because of the number of people with TBI that also have comorbid mental health issues, that it's very likely that you will be working with somebody with TBI. If you haven't already, you will in the future. And the main thing that we wanted to convey today is that the experience that you have as a clinician, as a case manager, somebody working with a person with TBI, and the person with TBI itself, the client, is going to be different from what the treatment with patients who don't have brain injury is like. And the couple of things that we wanted to point out are the fact that if you think about the most common treatment for mental health, counseling or psychotherapy or talk therapy is a very cognitively complex process that aims to improving a person's insight. Often people with TBI will have cognitive weaknesses, changes in their cognitive skills, cognitive impairments, and also reduced self-awareness, all of which makes the process even more demanding. So let's think about the fact that you may end up working with people who have not been identified with a TBI. In this case, what we hope to encourage you to think about is alternative etiology for the symptoms that you are observing. So for example, if you see a person who exhibits emotional lability, so they have mood swings and they are pretty severe and they have outbursts, instead of thinking about this as a symptom of bipolar disorder or borderline personality disorder, to think of it in terms of emotional dysregulation that often accompanies a traumatic brain injury. Now, if you work with a person who has identified as a person with TBI, then the work that you do has to focus on helping maximize the benefits that the person can get from treatment by capitalizing on their cognitive strengths and circumventing the cognitive weaknesses that they experience, and they can become obstacles. So what can these obstacles, how can they become obstacles? People with traumatic brain injury experience cognitive deficits in memory, attention, processing speed, executive function are some of the most common ones. So let's take something simple as an appointment. How can these diminished cognitive abilities interfere with the appointment? Well, first, let's think about how memory can interfere with an appointment. A person may forget that they had an appointment. That will mean that from your end, this person is not showing up. And does that mean that they're not invested in the treatment? They're not interested. They're not able. Your role is to think about, okay, how can I help this person remember the appointment next time? And we have a lot of that information in the guide. That's why I recommend downloading the guide and looking at more specific examples that we provide in there. But going back to the appointment, other issues that can get in the way. Attention. When somebody has attentional problems, they may be at home, they get distracted by something else, and then they forget to show up for their appointment. Executive functioning issues. They may lose the appointment card, or they may not have put it in the right place on their phone, and that way they will miss the appointment as well. Another common issue may be fatigue. People with TBI experience a lot of fatigue, and there may be a day when they cannot make it to the appointment. So keep in mind that these issues can occur, and they're not indicative of lack of motivation or a lack of investment and poor therapeutic alliance, but they are issues that you actually can help with so that the benefits of the treatment can be maximized. As far as interventions, there are, on the one hand, the existing interventions that are used very widely by mental health providers, that with some of the recommendations that we make about adjusting them to work in your work with people with brain injury can still be used. But there are also a lot of interventions that have been adapted to be used with people with TBI. There are, for example, cognitive behavioral treatments that have been developed to treat depression and anxiety for people with TBI. There are clinical trials on motivational interviewing, on mindfulness training. So there are many different existing interventions that you may be familiar with that have been adapted for this population. And these interventions are actually designed to be used by providers that are not TBI specialists. As was mentioned before, the role of a mental health provider is not, in this case, to treat the TBI and the cognitive deficits, but it's to work within the context of the TBI. So these interventions exist for that very purpose, and we have included a list of them in the guide for your perusal. I am mindful of the time, and I wanted to ask if there are any questions that you may have.
There are a couple of questions. I just lost my chat for a second there. One is, could you speak to the interventions and risk assessment of individuals with TBI and suicidal ideations?
speak to them in, well, let me think about what angle to take. Suicidal ideation is common among people with traumatic brain injury. We have been tracking in our clinical trials the percentage of people that present with suicidal ideation. Suicidal ideation usually occurs in the context of a major depressive episode or prolonged depression that may lead to hopelessness. So the approach that would be appropriate, monitoring and suicide prevention in any suicide prevention in any similar to any type of mental health intervention that you would use with clients that do not have brain injury would be appropriate. What you may find is that sometimes people with the severity, the cognitive profile of people with traumatic brain injury differs. So sometimes you may find that it is usually the ones that we refer to as higher functioning people, the ones that have higher awareness that may be presenting with a higher risk for suicidality. And what we recommend and what we have used are suicide risk assessment measures that are widely available. Maria, you can talk more about which one we are currently using in our emotion regulation study. And we find that they are very good at detecting, assessing risk.
Yeah, I think the traditional risk assessment measures and interventions are very effective with the TBI population. Oh, let me start my video. As long as I think the modifications that Dr. Tsalstides was talking about are made, I think that's the main caveat. There isn't a ton of studies looking at special interventions for suicidality for this population, but there has been a lot of evidence to support that, what you may already be doing with other people with these issues can be effective as long as they're modified to account for the very complex things that go along with a traumatic brain injury. Like I think Dr. Corrigan just really nicely put into the chat. They tend to be more impulsive. People with traumatic brain injury have that sometimes as an issue. So considering all these factors and adjusting the, perhaps frequency with which you see them, so on and so forth, adjusting for memory issues could definitely help improve the efficacy.
There's another question in the chat that asks, can you speak on traditional healing as it's related to TBI? Any thoughts there?
A little more context about traditional healing.
Crystal, if you provide some context, that would be great. Another question, is there one intervention that you would recommend over the others?
Oh, well, that would be conflict of interest, but we have developed, in the last 15 years, we have developed one intervention, a cognitive behavioral intervention for post-TBI depression that we published in 2014. We have developed a problem-solving intervention that is very effective and easy. It's a metacognitive intervention that people really enjoy, and they use it as a tool in their day-to-day life. And we have been working on a trial on an emotion regulation intervention that we are currently wrapping up our second round of a 5-year trial. And those have been the interventions that we developed, but many of our colleagues, and the ones that I would say have the best evidence would be the ones that I would recommend. So if you see something that is published and is a randomized controlled trial and has a sufficient number of participants enrolled, I would say then you are safe with that choice.
Great. Another question, how closely do you, I think this is directed to anyone, how closely do all of you work with the people who are studying CTE, chronic traumatic encephalopathy, for those of you that may not be familiar with CTE acronym? And maybe some of the contributors can answer that in the chat. There are a host of questions here. I'm just running quickly through these. Should individuals with TBI be taught rational behavior training and journaling to understand any challenges or distortions they experience?
Well, I can answer that. Yes, and cognitive behavioral therapy does exactly that. It's a way of helping a person become a better observer of their own thinking processes, and to determine whether these processes are founded in reality, if they are rational or irrational, and if they serve a purpose for them. So that would be definitely and it's a very effective treatment that has been used for anxiety and depression in people with TBI, and I think that's very highly recommended. Yes, I don't know if anybody else would like to chime in.
Great. Some context for the healing question. Crystal says, based on an individual's culture. So any alternative healing methods to be aware of?
Mm-hmm. So I'm going to speak as a researcher first, and then I'm going to speak as a clinician, as a person. As a researcher, I would say I would choose interventions that have an evidence-based, if I wanted to make a recommendation at a larger scale to an organization, to a group of providers that have come for training. Now, because I work with individuals, with people, with clients who have different belief systems and different philosophies and different worldviews, I would say that espousing that aspect of yourself, of the client's self, I'm going to speak to the client, of yourself, and sharing that and getting whatever strength you derive from that is very important. And especially if it's in the context of a therapeutic relationship where other components are also present that will facilitate ultimately our goal, which is independence, autonomy, and a better life.
Great. Thank you. There are a host of other questions. And Maria, if you, Theo, might be able to address some of those. We still have two more presenters I want you guys to hear from. And then if we have some time left, we can get to some of these questions at the end, possibly. Thank you.
Thank you.
Lindsay, Michael, are you ready?
Hi, everyone. Can you hear me? Okay. Hi, my name is Lindsay Gurin. I am a neuropsychiatrist here in New York City. I'm in my hospital office. And I am a white woman with blonde hair and sort of a pinkish red, deep pink shirt. Not very much art on the walls. My apologies. Everyone else is outdoing me on that front. But I am here today with Michael Chu, Dr. Chu, who is our brain injury medicine fellow. And we're going to talk today a little bit about just modifying psychopharmacological interventions for patients with TBI. And just to give you a little background, so I trained in psychiatry and neurology, and the way I got into that is basically I wanted to do psychiatry when I was in medical school, and I happened to spend time in a TBI clinic at the Veterans Hospital in Providence, Rhode Island, where I just really saw this very nice integrated approach to treating mental health issues as they arose in patients with TBI. And it's interesting because after that, as I sort of pursued psychiatry and neurology and was deciding about my path, I saw that that was really not sort of the case in most situations. And actually psychiatry residency and a lot of mental health training really doesn't focus on TBI as we've heard today. But I think because I'd had that early experience of seeing how well things could go when patients with TBI and other brain injuries have the appropriate treatment, it really motivated me to work in this field. And I think it just is a testament to how much education and training and, sort of you can really help people be able to give good interventions if you sort of know what you're looking at and what you're trying to do. Next slide. So I have this quote here by Sir Charles Symons, who was a neurologist in the 1930s, who worked a lot with brain injury. And this was at the time when neurology and psychiatry are really kind of the same field, and we have since diverged, I think, unfortunately. But the quote is, "It is not only the kind of injury that matters, but in a head injury, it is not only the kind of injury that matters, but the kind of head." Which I think is just so important to keep in mind in these cases, because this is really, we're treating a whole person. The TBI is an aspect of this, and TBI does cause changes to the brain that do need to be understood, but in the context of who this person is, in terms of their personality and their life before the TBI, their life now, any kind of pre-existing psychiatric or other mental health things that they had going on. And so, I think the important thing when I was approached to work on this this amazing project really is thinking about, that we already are doing this in the mental health assessment and the psychiatric assessment. We're already thinking about who this person is, their sort of biopsychosocial context, and how to kind of understand some of the sort of behaviors that they're having, with understanding a little bit more about TBI can really help to kind of enhance this assessment and treatment strategies that we're already doing for these patients. Next slide. So overall, I'll just talk a little about the approach and some of the assessment, and then Dr. Chu will take over for a little bit more of the examination and interventions. But the overall goals of psychiatric care and brain injury. So number one really is to try to improve diagnostic clarity. And so we heard a little bit about this, how it can be confusing to figure out sort of these symptoms of bipolar or these emotional dysregulation symptoms related to brain injury. So what you're really trying to do is figure out, are there some symptoms here that, can resemble a primary psychiatric illness that can give a framework for understanding these problems? Or are some of these symptoms actually, directly related to the TBI? So like cognitive impairments and other things that we've heard about. You want to try to identify specific target symptoms that are potentially, can be intervened upon, and then treat those symptoms. And so the sort of mainstay really is the non-pharmacological interventions that we heard about, therapies and sort of other things. Pharmacotherapy can be helpful as well, so medications, and we'll talk a little bit about that. To decide about medications, and this is sort of where the difficult part is, really the way that I think about this is either, sort of using data that is sort of derived from primary psychiatric illness and medications that are used for certain psychiatric problems, or medications that have data for use in TBI. There are no medications on label for use in TBI right now, but there are a number of medications that have good evidence to back them up in the TBI population, so you can do that. Or you can take what you know about the injury and the person and develop a hypothesis about what brain pathways and what neurotransmitters sort of might be disrupted, and try to target the symptoms that way. Next slide. So an important thing when you're going into this assessment, we heard a little about this from Dr. Corrigan, how recent was this TBI? And so if you're in the acute acute or post-acute period, the injury happened very recently, you want to think about, one, could there be some post-traumatic amnesia present? And two, is this person still sort of actively recovering? And so after a TBI, especially in the early phase, we do expect a lot of natural recovery. And so some of the symptoms that we're seeing in the early phase can be kind of a moving target. You also want to think about, are there medical complications that could be contributing? So there are a lot of medical issues that can come up after a TBI. So think about how those might be contributing to some of the mental health issues. In the chronic stage, you want to think about, could there be some cognitive problems? So we know, we're sort of starting to learn more about this, that TBI is a chronic illness. There is, some chronic, we think, inflammatory process that can happen after a TBI, more in some people than others, but that in some people does result in cognitive impairment that progresses down the line. And so could there be some cognitive impairment that's sort of contributing to some of the features that we're seeing? Next slide. And so an important, thing, I mentioned this with sort of thinking about medically, and if you're approaching this from a medication standpoint, we already do this as part of the psychiatric assessment, thinking about the medical review of systems, but in particular with traumatic brain injury, you want to think about neurologic complications of TBI that could make psychiatric symptoms worse. And so some common ones I've listed here: headaches, chronic pain, and also the medications that are used for pain. These can sometimes exacerbate mental health issues. Seizures are fairly common in this population. Also, seizure medications can cause mental health issues. Dysautonomia, and so this is a big one, both in mild brain injury and also more severe. People can have sort of this changes in heart rate and blood pressure, and sort of changes in the sensitivity of their autonomic nervous system to different stressors that can trigger anxiety, can trigger agitation. And so identifying this as a problem, sometimes you can target this directly and reduce the psychiatric kind of manifestation, reduce the anxiety as a secondary effect. Finally, visual disturbances are also quite common. And so particularly in mild brain injury, a lot of patients will describe, sort of having difficulty reading, focusing, difficulties with eye movements, and this can contribute to a lot of cognitive fatigue, a lot of psychological distress, sort of not being able to move through the world, seeing things the way you're used to. So it's good to identify that as well. And then finally, we heard about this in the screening discussion, but you want to get as much detail about the injury as you possibly can. So how severe, what was the extent of the injury, where was the lesion in the brain, if there was one seen on imaging, and sort of use that to inform your approach. Next slide. Okay, I think I'm actually going to hand it over to Dr. Chu to take it from here.
Thank you, Dr. Gurin. My name is Mike. I am a brain injury fellow at NYU, and that's a division of physical medicine and rehabilitation. I describe myself as a middle-aged Asian male, black hair that is short. I'm wearing glasses, a light purple shirt, which contrasts my darker purple tie. I'm sitting in a workroom, and you may see behind me some of our esteemed NYU residents. So the importance of supplementing psychiatric mental status exams with cognitive assessment, cannot be understated. It is helpful for screening, but also for trending and tracking the efficacy of any medicines or pharmacologic or non-pharmacologic interventions that you may be using to treat brain injury and mental health. We provide some examples here. The Mocha, Montreal Cognitive Assessment. It may be performed by clinicians or other members of the healthcare team, including neuropsychologists, if available. The SWAMs and the mini mental status exam are also other options. And like I mentioned, these may be used in the beginning, but also may be reapplied throughout the course of treatment to better quantify and qualify how your treatments are working. Next slide, please. It is important to not just use the information that you're gathering in the moment, but also previous information from the patient's past, and also considering additional information that you may want to gather. And this may be in the form of brain imaging, MRI, functional MRI, EEG may be useful in the setting of episodic symptoms, or in some cases, patients have symptoms that don't really make sense. It can be helpful maybe to identify subclinical seizures, which may contribute to a lot of the symptoms that brain injury patients present with, including agitation or disorientation. Blood work can be helpful in addition to standard psychiatric labs, such as thyroid function and B12. And you may want to include some pituitary hormone labs, screening labs. It really is, tailoring the lab work and the imaging that you do to the patient's symptoms. So certainly understanding and exploring the various symptoms, the constellation of symptoms that brain injury patients and mental health patients have, tailoring your diagnostic tests to what they are reporting can be extremely beneficial. Next slide, please. So I think that it's perhaps been said over and over that having a primary psychiatric diagnosis can certainly that can be exemplified in a brain injury patient. It unfortunately can make treatment more challenging, but at the same time, identifying underlying psychiatric illness can help us better direct the care. So that knowledge, although it reminds us that that this may be a more challenging case, that knowledge of an underlying psychiatric diagnosis can actually help us guide our treatments and tailor the treatments that a particular person needs. There are a variety of symptoms. I appreciate that there's a variety of symptoms that come with various psychiatric diagnoses, and so even if a person does not present with all of the symptoms of a specific diagnosis, we can apply best fit diagnosis to treat this patient. Symptoms specifically related to brain injuries, TBIs, some of these may overlap with psychiatric diagnoses, but it may also be a direct result of a brain injury. I'll allude to what Dr. Gurn mentioned with the behavioral psychosocial model that can be that can explain a lot of this constellation of symptoms that are shown on the slide, which may include sleep-wake disorders, emotional discontrol, issues with mood and behavior, a lack of motivation, cognitive impairment in domains such as memory, executive processing, inattention, and certainly agitation, which is often driven by multifactorial causes. Next slide, please. So I will say that in the guide, there are a variety of pharmacologic and non-pharmacologic options for our population of patients. But these are the guiding principles that sort of overall will allow us to pick the best interventions. So first is important to know your target symptoms. As it says here, without a map, you cannot get to your destination. And so in terms of picking the treatment of choice, knowing the symptoms is important to be able to pick the best first agent. When possible, add by subtraction first. I like to give the example of an agitated patient who is on many medications, possibly neurostimulants. And instead of treating by adding a medication that calms them down, it may be helpful to remove medications that ramp up the patients. And so sometimes taking away something may be a better choice than adding another medication. Start low and go slow. Brain injury patients, TBI patients are more susceptible to medications because of their brain injury. And so when starting a new therapy, it is important to, it is valuable to start with the lowest dose possible and up titrate slowly. The response may be, their response to medication may be, they may have a very dramatic response to a low dose of medication due to their injury and the way that the brain is reorganized after an injury. Reassess frequently. So whenever you make a change or start a new medication, assess for medication effectiveness, but also be mindful of side effects, and if needed, make adjustments to medications, if in a timely manner. Avoid polypharmacy, if possible. Oftentimes in a hospital setting, patients end up with a lot of medications, and just be mindful that sometimes it is valuable to take into account that not, if you don't need to add more medications, then don't. You don't always have to keep adding medications. So it is valuable to review the medication list. Oh, sorry. So it looks like we're out of time, but the next slide you can read is available on the website. And then in the subsequent slide, next slide, please, we provide a list of medication options. And just want to close with, non-pharmacologic interventions are just as important as pharmacologic ones. And so, a combination of the two, it will lead you to having good success in treatment.
Thank you so much to the two of you. That has been the fastest 90 minutes I think I've ever experienced. And there are a slew of questions. Michael and Lindsay, I'm just going to throw one at you quickly. Any recommendations particular to OCD and therapy?
That's a great question. So I think, and I would let the, neuropsychologists maybe talk about the therapy aspects. But, I think the thing is that, as we know, in general sort of treatment of OCD, it often is a good mix of CBT and exposure response prevention, potentially, if the person is able to participate at that level. And then also SSRIs. And so, I think this is, again, is an example of, if you can identify something that looks like OCD, even if it's not exactly, or there's other features that are kind of weird, it still makes sense to treat as you would standard OCD. And actually SSRIs, we sort of didn't have a chance to go deeply into the medication specifically, but SSRIs are great in TBI for a number of reasons. And so, potentially could even help with other features that are associated with the TBI as well.
Great. I see some other questions that I think John's been answering related to medical cannabis and brain injury and substance use disorders. I'm just quickly scrolling through here.
If people can stay on for a few minutes, we have an evaluation poll at the end, and we would love for people to take it. So if you can bear with us and stay with us for a few more minutes.
Great questions. I wish we had more time for that. Thank you so much. We hope this has been beneficial for you. I want to say thank you once more to all of the presenters today and for contributing to the Behavioral Health Guide. And please use it and reach out if you need us. Terry?
Thank you, Maria. So we have we have a poll. There's like 6 questions. If you could take some time, you see it right now. This is for us to be able to improve future webinars that the TBI TARC puts together. So please take a few minutes to answer the polls, and you can also reach out to us. You can send us an email if you have any feedback about how we can improve future webinars. And thank you for being with us today. And you can scroll down. If you go down, there's 6 questions on the right-hand side. Thank you. And this has been great. I've learned a lot, and I've read the guide. As we noted, the guide is available on the ACL website. We will make the recording available on the ACL website, and we want to thank our the Administration for Community Living for sponsoring us in this webinar, and we look forward to having you join us in future webinars. How are we at? We're halfway done, so please, thank you, and we hope to see you all soon. Just waiting for this poll to get a few more people.
Terry, we are saving the information in the chat and the links that we shared in the chat. So we'll get that back out when we post the webinar, correct?
Yes, we will. Oh, I can also send it. I'll see whether it's posts in the webinar or send it an email, because we are posting the recording on the ACL website. So
great.
And a reminder that you can download the slides and that you can also download the document. And thank you.